Yeah. Good morning. Good morning. Today we have a ward round scenario for discussion. We have selected a topic for abdominal trauma, but it will be a comprehensive discussion and presented by Dr. Ishitala, who is a third year junior resident at Ramakrishna Mission Seva Pratishthan, Vivekananda Medical Sciences. And today our examiner will be Dr. Ramdeep Rai, who is a consultant hepatobiliary surgeon and transplant surgeon at Apollo Clinical Hospital, Calcutta, a very avid teacher. So I request Milind to share the screen, the scenario, and then we'll proceed with the discussion. Milind, you share the screen and read the scenario for Shita.
Good morning, sir.
Yeah, good morning.
A 40-year-old gentleman met with RTA and brought to the emergency with a complaint of pain abdomen, distension, and respiratory distress. How will you proceed?
Okay.
Sir, may I go on?
No, just wait. Let Dr. Rai takes you through.
Yes, good morning. So I haven't seen the scenario yet. So this is how we start off. So, so you have the slides with you. Hello.
Sir, this is just one slide, just the scenario.
It's just a ward round scenario, sir, and then through question and answers, the
Okay. So are there further slides after this?
No, sir. This is just the one scenario, sir, for the ward.
This is just the one scenario.
Yes, sir.
Okay, and then we continue the conversation as.
Yes, sir.
Great. So yeah, are you there? The video's going off. Okay. Yeah. So just one sec. So yeah, Dr. Ishita, how will you proceed?
Sir, I will like to proceed as per the ATLS protocol. Sir, first of all, when the patient arrives, then we will see if there is any external source of any bleeding. So we will try and manage that by tourniquets or like as in this present scenario, the RTA with pain abdomen distension, we may have to put a pelvic binder, and then we go on to further manage the airway. Secure the airway. We ask the patient if he can say his name. That is the most simplest method of knowing if there is any airway distress. But at the same time, if we comprehend that there may be some airway obstruction in near future, we may as well have to intubate the patient. And or otherwise, if the GCS is less than 8, then we have to directly intubate the patient. After this, we will go for the breathing. And in the breathing, sir, we will see for the breath sounds, the tachypnea, and as already said that there is a respiratory distress along with abdominal pain and distension. So we will go for we will auscultate, and if we perhaps think of any if any decreased breath sounds in lieu of any hemothorax or pneumothorax, then we have to immediately put a drain based on clinical examination only, rather than wait for any investigation to be done. After that, we go on for we go on to the circulation. And if there is already abdominal pain, distension, and respiratory distress, maybe because of hemodynamic instability also, as in grade as in hemorrhagic shock like grade 2 and grade 3, we may encounter respiratory distress. In that case, we will directly put 2 wide bore cannulas, maybe of the 16 gauge or 18 gauge, and then we will quickly try to resuscitate the patient, giving giving approximately 1 liter of fluid within an hour, and we see the response of the patient. And we wait for the response. At the same time, side by side, we also do the fast examination to note for any intra-abdominal bleeding in any of the 4 quadrants. And then we go to assess the GCS and any other limb extremity disability. After that, we go on for the exposure of the patient, at the same time maintaining the maintaining the hypothermia by warm blankets, warm fluid, and covering. After that, if we are done with the if we are done with the primary survey and we have resuscitated the patient, then we can go on for sir. And in amidst this, we must also send blood for CBC, INR, and cross matching. If at all there is any hemodynamic instability due to blood loss, so we have to transfuse it. We have to replace it with blood. And after completion of the primary survey, we may go on to the secondary survey after an able resuscitation. And secondary survey will comprise of again further examination of head to toe. And after sir after sir eliminating there is no pelvic X-ray, as we have already put a pelvic binder. We have eliminated that there is any presence of pelvic fracture. Then we can log roll the patient to look for injuries at the back. And after seeing that, we may go on for further investigations like ultrasonography of the abdomen.
Ishita,
Yes,
wait. Ishita, just we can have some discussion on the primary part. She said that ATLS protocol. I heard you said you apply a pelvic binder. Why?
Yes, sir.
That is not the first step we do.
Sir, if there
Pelvic
is
binder
any
comes when you have a suspicion of pelvic fracture. We have not done anything. The first
Sir,
step is not. Yes.
Sir, when the patient comes for the RTA, pain abdomen distension with respiratory distress, there may be it is a suspicion for
That is not the
huge
first
blood
thing you
loss.
do in emergency. Try to understand. In ATLS protocol, there is a chronology of management. Okay, it's not first thing is not ask for a pelvic binder. Rather, you ask for a cervical collar rather than going for a pelvic binder. Okay, so you follow the exact ATLS protocol. So you go to primary survey, na?
Yes, sir.
Go slow.
Sir, okay, sir.
Yes.
Sir, on arrival of the patient, do we not control any active bleeding, which we like? First step is to control of any external
that will
bleeding.
come gradually. You see, in ATLS
Okay.
protocol, they have clearly defined the priorities. When the patient comes, first priority is maintaining the airway.
Okay, sir.
So in this patient, you are assuming that he said he has got pain abdomen. So patient is communicable probably. And then he has abdominal distension. So you are probably going to a patient who has got either a isolated abdominal injury or a part of multiple trauma, he has abdominal injury. So to assess that, you go with this. How? By asking a question, you can make out that patient has got good airway, a patent airway.
Sir, we may ask the patient about the name. From the voice, sir, we can come to a conclusion.
If he respond properly to your question,
and there is no nasal intonation.
Yes. Then breathing.
Yes,
for
sir,
breathing assessment in primary survey is not putting a chest tube straight away. You first assess the breathing. Okay, assuming that patient has got isolated abdominal injury, go into that discussion part. All right. We assume that this patient has a communicable, good coma scale. He has no competent head injury. So that might be a direct impact in the abdomen and suspicion abdominal injury. So Ishita, you can start from this point. You have gone through these steps. A, B, C, D, E has been done. No component of head injury. He has got an isolated abdominal injury with these features. How will you proceed?
Let us, if I may join in,
Yes.
let us assume that you see the patient and the primary survey, you see that there is a bruising on the right upper part of the abdomen and lower part of the right chest. And you take the history and you say, there was a compression that the patient or the family says there was a compression on the upper part, right side of the chest and lower right side of the upper abdomen. Now, what are your thoughts and how will you proceed?
Sir, we can feel for any rib fracture, and if there is any bruise and along the right upper quadrant, as mentioned by the patient, and we can even look and by the clinical examination, we may suspect a liver injury in this scenario.
So right side,
and along with past, sir.
Yes. So
confirming.
right side of the chest, lower chest, and right upper part of the abdomen. So you will think what? Two things you will think straight away. One is whether the patient is having anything in the
Chest.
chest, another is liver.
Liver, solid organ injury.
Yes, but what Dr. Shah has already said that we are looking at only abdominal injuries now. So we have told you that there are no other injuries. So then how do you look at proceed?
Sir, after if and sir, we have to. So this is a blunt trauma injury. So after this, we do the fast. If the patient is
No,
hemodynamically
Ishita, your scenario is pain abdomen only. You have to go through some little part of history again. You understand? We said it's abdominal injury. And the scenario was given pain abdomen. So patient may not have isolated abdominal injury, liver injury. Keep in mind, patient may have other associated injuries.
Okay, yes,
So you
yes,
need
sir,
to
yes,
ask
sir.
some more questions to find out
Yeah,
the
yes,
status
yes,
of the
yes,
abdomen.
sir.
Okay. So he has
Yes,
got
sir.
pain abdomen. You are not interested to know how is this pain, why did the
From
pain started, how the pain has generalized or not. Okay, this may give some other clue to your spectra of abdominal injury. We are not talking of an isolated liver injury just because given the scenario. You should always keep in mind it can be a comprehensive assessment of the abdomen.
Sir, from the history, sir, we know that this has been one road traffic accident, and if the from the bystanders or if any relative is available, we will ask for the condition of the patient before the injury and the mechanism of injury or the status of the patient if there is any delay in recovery after the injury, and after arrival at the emergency bay we will assess the patient for the vital signs to check for the SpO2 by pulse oximetry, and clinically by assessing the abdomen. If there is any distension, as mentioned that there is distension of the abdomen, we will think of any hollow viscous perforation or any solid organ
So
injury.
maybe you can tell the examiner at this stage, sir, I have done the primary survey. I have done an initial assessment of the patient. And my impression is that the patient is as of now not hemodynamically is stable. There is no life-threatening emergency right now. So I would take a few minutes to get a detailed history and information which would guide me further about the further investigations and plan of management. So you must, in the emergency, make a distinction between a stable patient who will allow you certain detailed evaluation or someone who is crashing at that moment. Okay. So once we have established that the patient is not crashing at that moment, you will take a detailed history about the mechanism. Then
history is not complete. I can exclude a kidney injury by asking question.
Sir, we will check for any flank
check.
hemorrhage.
History. I'm talking of. You see, patient has got an abdominal injury,
back
and
pain.
there are
Sir, patient will complain of back pain.
So you need to know about the detailed history of the pain itself. Number one. Number two is what else apart from pain? Patient has got
a shoulder tip pain.
peritonitis.
Sir, shoulder tip pain.
Yes.
Both on the right and left, maybe as per the injury of the organ. Shoulder tip pain and associated with nausea, sir, and there may be also vomiting if there is any bowel injury.
Not any peritoneal irritation can cause vomiting.
Peritoneal injury can
Okay,
cause.
it's not that need to have a gut injury. So you should ask these questions. Next is he may have associated renal injuries, where he may pain in the flank.
We have to ask for hematuria, sir. We have to ask for hematuria.
And then patient may have as you said, patient may have appendix injury. There may be associated urethral injury. So the scenario of abdominal injury, you should ask all the questions. And by asking this question, you can make out whether he has got any other acid injury or not. Okay. How do you suspect a urethral injury from history? We discussed last day.
Sir, we will suspect sir, there will be urinary retention, sir. Urinary retention, and sir, and it may also appear with Sir, rupture of the bladder, sir, with intraperitoneal
These
extravasation
are,
of
I'm
urine.
not asking pathology. You ask some questions and make out, yes, this patient might have some pelvic injury or some urethral injury. So he may have retention. He has not passed urine since the accident.
Yes.
He
yes.
may have bleeding per urethra. He
Yes,
may
sir.
have bruise in the,
Blood
he may
at
have
urethral
some
meatus
bruise
can
in
also
the
be
perineum. So you should
perineum.
ask all these questions. So, but we will discuss primarily the liver injury today. But discussion on liver injury will not be complete without a comprehensive assessment of the patient with a good history and then examination. Okay. So you should ask all the points in history. Don't jump from the history. Don't jump from the investigations. So history is very important for assessing the abdominal injury. Then if we now come to the examination in secondary survey, we have done the ABCD and you are assuming this patient got isolated abdominal injury. What on the examination is important? Starting with the vitals and then the abdomen.
Sir, I did not get the question. Can you just repeat, sir?
We have done the primary survey. We have taken the detailed history of the abdominal injury, and now we are going for the examination. Okay, in examination, how do you assess the patient? Think of vitals of the patient and think of the abdominal part. You are not going to the other injuries. We just confine the abdomen. Is vital assessment important in this patient?
Yes, sir. Yes, sir.
Yes.
So vitals are integrate part of all abdominal injuries, all kind of injuries rather, and it starts with the blood pressure monitoring with pulse rate and respiratory rate, and if the patient is maintaining saturation. After that, we go on to examine the abdomen to look for the abdominal distension and any bruise if present, and the peristalsis we may hear, and so the type of respiration the patient is taking, if it is abdominal or abdominothoracic, and sir, if there is any ecchymosis at the umbilicus, and any collection or any flank ecchymosis, and sir, then after that we will go for fast, sir.
You will not palpate the abdomen. You will not do a digital examination of the rectum.
The digital examination of the rectum will only be done after ruling out pelvic fracture, sir.
Ruling out?
Sir,
you will not do digital examination before you do an X-ray. Clinically, you cannot make out. You see, what I'm saying is, try to understand, you have to do a good clinical examination because now you're in the secondary survey. You are not primary survey. In secondary survey, you are supposed to do a detailed history and examination. So abdominal examination, there are a lot of things to be seen in palpation. Percussion is important to look for obliteration liver dullness. Listening to bowel sounds are important. Generally, examination is important. Okay, any bleeding per rectum is important. Okay, and then there are some clinical tests also to know about the fracture pelvis. So what I'm saying, you go gradually with the clinical assessment, and then E-fast is definitely to be done. I understand, but you just tell us the points on examination which will help you in diagnosis, because already the scenario is a patient has got a bruise in the right upper quadrant, so you have strong suspicion of liver injuries. But most important is liver injury isolated or liver injury plus some other intra-abdominal injury. That is important. So come on. What is palpation in the abdomen?
Sir, palpation first, sir, we will check for any superficial tenderness and rhizome temperature, and then we will see for deep tenderness and in all the quadrants, and we will check. And sir, after that, we will check for the obliteration of liver dullness.
Before
And
that, do you think the patient might have some rigidity in the abdomen?
Yes, sir. Sir, there may be rigidity, rebound tenderness may be there, sir. Rigidity may be there, and sir, after that, we will auscultate.
When you're saying that you will do superficial palpation, deep palpation, you cannot just say that in the exam. You have to say that I have to do superficial palpation and deep palpation with the idea of looking for evidence of guarding, looking for evidence of rigidity.
Yes.
Okay, that is the purpose of it. Okay,
Okay, sir.
then
Okay. Then
Then we will go for percussion, where we check for the liver.
can liver be palpable? Can spleen be palpable in a trauma
Sir,
scenario?
sir, may not be palpable, sir, because already for the hemoperitoneum or the pneumoperitoneum, the distension.
Don't think of always a hemoperitoneum. There are some situations where there may be a hematoma which is expanding the liver, there may be hematoma which is expanding the spleen, and you may palpate, which might be then a tender to touch. Okay, I am not saying it will be palpable. What I am saying is, while palpating, you should comment that I will palpate the liver, I will palpate the spleen. In case of only subcapsular hematoma, sometimes you can feel the enlarged liver of the spleen.
Okay.
In laceration, no, you may not palpate.
and it's very important for the spleen because splenic trauma is more common in enlarged spleens. Patients who have thalassaemic spleens and all, so you might actually find a big palpable organ.
Yes. So you can palpate a perineal hematoma. If you have a renal injury, you can find there is a flank hematoma, which is a perineal hematoma. You can palpate that. Okay, so what I'm saying is, you give a complete approach to abdominal examination, and then do the palpation, percussion. Percussion, you see, percussion may be just a percussion tenderness because of hemoperitoneum or a perforative peritonitis.
Sir, sir, as
Yes.
said, percussion, and after that we will go for auscultation of bowel
Yes.
sounds, and to note for any bruit. Um, um, and after that we'll go for digital rectal examination.
When do you expect bruit in abdominal trauma? Patient has come to emergency within 2, 3, 4, 6 hours of accident. What is the idea of listening to the bruit?
Sir, there may not be fascial. Sir, there may be a mild fascial injury. So because of that, bruit may be heard, sir.
No. You don't find bruit in an acute setting. Okay.
Okay, sir.
Bruit may be found in a delayed arteriovenous fistula or whatever, but in acute setting, it is unlikely that you listen to bruit in abdomen.
Okay, sir.
Okay. Chalo.
Okay, sir. So after that,
so
we
done.
will go.
At the end of clinical examination, you find, I'll give you a scenario, you find that patient has got extreme tenderness in the right upper quadrant of the abdomen. There is mild guarding or rigidity in the right upper quadrant of the abdomen. Apart from this, he has got soft abdomen, the rest of the area. There is sluggish bowel sounds. And if you, when you percuss, there is no obliteration liver dullness. But he has got extreme tenderness in the right upper quadrant, and there is suspicion of fracture reeve on the right side. So that is the finding in this patient. What next?
Sir, first of all, sir, fracture rib, we have to rule out if it is associated with any flail chest. And in that case, sir, in a 40-year-old gentleman, we have to observe the patient and give adequate analgesics. At the same time, we have to administer fluids to resuscitate. And if the patient is hemodynamically stable or a responder to resuscitation, then we can admit the patient and observe. And if observe for any signs of deterioration later, and if the patient is not a transient responder, which may if the patient may deteriorate after some time, then we have to go for an whole body CT scan with IV contrast to know the exact mechanism of
Whole body CT
injury.
scan means? Whole body CT scan means don't go into all the scenarios. I've given you a specific scenario. Patient does not have head injury. He
Sir,
is,
whole body, sir, then CCT whole abdomen, sir.
wait, you have to go step by step. We have given you a scenario that there is a tenderness and there is suspicion of liver injury, and you are rightly said there is some suspicion of chest injury also. Okay, patient has got fracture rib, may have associated pulmonary injury. So what is the approach? You have done the ABCD part. When you suspect the patient has got a suspected liver injury, what is the first step in assessment after the examination?
Sir, fast, sir. Fast
Yes.
I have already included in primary
Oh.
survey. So you said,
No, primary first is not part of primary survey. You have to understand.
okay, okay,
First should be done after you have done the primary survey, not a part of primary survey.
okay,
First
okay,
should be done. The guideline is you should complete the first within half an hour of arrival of the patient in
yes,
emergency.
yes, sir, yes, sir.
So in primary survey, none of these ABCD says first is one of the component of that. So first is once you have done an assessment, you have completed ABCDE, and particularly the patient has got multi-trauma, first is mandatory. So abdominal injury, obviously first. What do you see in first?
So we will see for, sir, perihepatic collection, perisplenic collection, the pelvic collection, or the pericardial collection. And sir, if we do extended fast, then we have to include the pleural collections as well.
Fine. So what do you expect? Patient has got suspected liver injury. What do you expect in first?
Sir, I suspect that there will be collection in the right upper quadrant or in the perihepatic region.
It can be other part also. If you have got a major liver injury, you may have hematoperitoneum. Okay, so you may have this collection confined to the perihepatic, or there may be
Or
collection in other areas also. So
diffuse
first is
peritonitis.
positive. Now you declare the first is positive. What next?
Sir, with fast positive patients and hemodynamically stable, then we can try. We can
Now you
keep
have
the
a two
patient.
scenario. You have two
Yes, sir.
scenario. One is
Yes, sir.
hemodynamically stable, or patient may be hemodynamically unstable.
Yes, sir.
Do you know
Sir.
the WACS has given the criteria for hemodynamic instability? How do you
Sir,
define hemodynamic instability?
Sir, with presence of shock, signs of
Means what?
peritonitis.
Define the criteria. Shock is a general term. What are the criteria specifically described to say, yes, this patient is hemodynamically stable, this patient is unstable? At
Sir,
what point of criteria you say?
The signs of peritonitis, leukocytosis
No,
more than 15,000.
no. Peritonitis is not the criteria for hemodynamic status. Peritonitis is a different scenario. Hemodynamic status is something else, some parameters. Blood pressure, how much?
Sir, systolic blood pressure will be less than 90, sir.
Yes, good.
Systolic
Pulse.
Pulse, sir, more than 110. And
some say 100 or 120. Fine, pulse. Then what else?
Sir, respiratory rate, sir, tachypnea more than 35 breath sounds per minute. And sir, with leukocytosis more than 15.
No leukocytosis. It's a clinical assessment. Then patient has got low tissue perfusion, which will be reflected by cold, clammy skin and delayed capillary filling. Okay, these are the criteria. If you find that these are the patient who has got these criteria, you declare that this patient is hemodynamically unstable, because that has got a bearing on subsequent management also.
Okay, sir.
Okay, so
is pulse rate a criteria?
Yes, WSCS has given that. WSCS has given the hemodynamic stability.
That pulse is a criteria.
Yeah. Okay. Shock, blood pressure, pulse rate, cold, clammy skin.
Yes.
And the
basics.
Respiratory shortness of breath.
Capillary
refill. Okay, so what is the approach? Patient is hemodynamically stable and you suspect liver injury, and patient has got some amount of rigidity and tenderness in the upper quadrant. What should be done next?
Sir, we will go for the CCT scan, sir, with IV contrast.
Yes.
To determine the grade of injury, and also to determine, sir, any complication associated with the liver injury, and also, sir, associated other organ injury.
Yes. So CCT is the gold standard.
Yes, sir.
CCT is the gold standard for assessment of this injury.
Yes.
A simple chest X is important.
Pardon, sir?
A simple chest X is important in evaluation of abdominal trauma patient.
Yes, sir.
How?
So chest X-ray will delineate, sir, if there is any rib fracture, pulmonary contusion, or if there is hemothorax, pneumothorax associated with, if any diaphragmatic injury is there, and or herniation of abdominal organs in the chest. And sir, this here under diaphragm to
yes,
denote
that is very important. For abdominal trauma point of view, If you have a air and a diaphragm, that indicates patient has got a hollow viscous perforation. Okay, so this is
Yes, sir.
important also. Next, you've done CT scan and you to grade the injury. Dr. Rai, you can discuss about some grading of injuries.
So what do you look at in the CT scan? What are the possible findings that you may find?
Sir, we will check for pneumoperitoneum, hemoperitoneum, any visceral injury,
Come to
laceration,
liver
any
injuries.
parenchymal.
Ishita, come to liver injuries. In CT scan, what are the things you look for and how do you grade? There is a AST grading of liver trauma.
Yes, sir. Yes, sir.
How do you assess that in CT scan?
Sir, I'll just define the grades, sir.
Yeah, you can do that.
Sir, in grade 1, sir, there is a subcapsular hematoma, less than 10% surface area associated with plus minus capsular tear, or there can be parenchymal laceration less than 1 centimeter, depth. And in grade 2, sir, there is a subcapsular hematoma with 10 to 50% surface area and parenchymal laceration with 1 to 3 centimeter depth, intraparenchymal laceration, and no sir, intraparenchymal laceration and intraparenchymal hematoma less than 10 centimeter. And in grade 3, there may be subcapsular hematoma with more than 50% surface area, and there is ruptured subcapsular, or there can be ruptured subcapsular hematoma and intraparenchymal hematoma extending more than 10 centimeter.
Okay, it's very complicated. You read it out.
More than 10
You
centimeter.
read it out. What is grade 6?
What
is grade 6 injury?
Sir, grade 6 injury is 75 to 20, more than 75% liver disruption.
Grade 6.
The most
grade 6 is one line.
Sir, I'm telling, sir. Sir, it is vena cava injury, retrohepatic vein injury.
No.
So leading to what? Leading to what?
Yes.
Even if it's vena cava, what is happening to the liver?
Sir,
hepatic
avulsion.
Hepatic
of
devascularization.
Avulsion.
Is a hepatic vascular injury, hepatic devascularization. It's a grade 6 injury. Do
So
you know a World Society of Image Surgery has come out with a different classification of grading of injury? WSES. What is that?
I'm sorry, sir. I am not
You
aware
not
of
read it.
it.
Okay. Which is that now? The WSES has classified the grading of liver injury based on the anatomical injury. They have taken into account the AST grading plus hemodynamic status. And they classify liver injury into mild, moderate, and severe.
Okay.
Mild, moderate indicates the grading, different gradings. But severe is one where you have any grade of injury, maybe 1 to 6, with hemodynamic instability, because that is a crux of the management of liver injury. So WSES classifies liver injury into minor, moderate, and severe. And severe is any injury 1 to 6 with hemodynamic instability. Okay, so in CT scan also you should look into this and grade the injury. That is, you need a very good CT scan report. Why the grading is important? Yes, Dr. Rai.
When you're looking at the CT scan, so what kind of CT scan has been done? What did you ask for?
Sir, I asked for, sir, non-contrast phase and, sir, arterial phase and delayed portal venous phase with IV contrast.
So this is called, what kind of CT is it called? This is a
contrast enhanced CT.
What kind? What contrast? How many phases?
So triple phase.
Triple phase. What are the 3 phases?
Sir, non-contrast phase, arterial phase, and delayed portal venous phase.
Non-contrast is not a phase.
Yes.
Non-contrast is your basic. It's a non-contrast. When you're looking at a contrast CT, it's a triple.
Arterial, venous, and delayed portal venous phase.
So arterial, portal, venous, or you can say arterial, portal delayed, or arterial, venous delayed. Those are the 3 phases.
Okay. Okay, sir.
So in the plain CT, what will you see? The plain non-contrast. What are the findings?
Sir, in non-contrast CT, sir, we will check for, sir, any hemoperitoneum, sir, hemoperitoneum, and any disruption of liver parenchyma.
Okay. And you may see pneumoperitoneum.
pneumoperitoneum. Yes, sir.
In the arterial phase, what will you see?
Sir, our contrast blush.
First, you'll have to trace all the arteries in
Yes,
the
sir.
abdomen one by one, starting from the aorta and into every single branch. And what will you see? What do you have to see? You have to see the continuity of the vessels.
Yes, sir.
One. What do you see next?
Sir, contrast blush anywhere, sir.
Extravasation of
Extravasation. Extravasation, and also, sir, pseudo aneurysm, sir.
Okay. Any
in acute setting, student doesn't come. You should understand. If the patient is coming to you just now and going for a CT scan, don't expect to see a pseudoaneurysm. These are delayed
Sir,
appearance.
if the patient has arrived, sir, after a certain time, like
so
he
that
was
is
stable,
not
so
how you
he had
answer.
not
That
come
is
to
not
the
how you
emergency.
answer the examiner. Your idea is when suppose your examiner, this is an exam setting.
Yes, yes,
So
sir.
the examiner will tell you why are you looking at arterial pseudoaneurysm in the acute setting. So you have to say, yes, sir, it has no relevance in the acute setting. I will only look at a pseudoaneurysm in the follow-up CTs
Yes.
later on.
Yes.
Your first attempt should be to tell the examiner, yes, sir, I will.
Yes.
You know, instead
Okay.
of trying to say 1 point against.
Okay, sorry,
Okay.
sir.
So you will look for, so you will say, I will trace out all the arteries. I will look for any evidence of discontinuity in the arterial path. I will look for any extravasation of contrast suggesting active bleeding. And later on, I will also be looking at in follow-up CTs, I will be looking at evidence of aneurysms and pseudoaneurysms in the arterial. Done. Next, venous or portal venous phase. What will you see?
Sir, venous phase, sir, I will check for any disruption in the retrohepatic.
Which phase
sir,
is first, portal or venous?
Sir, venous phase is first, sir.
First portal, then venous, then delay.
Okay, sir. Okay, sir.
So in the portal vein, what is there to see?
Sir, portal vein will help determining the circulation in the abdominal viscera. Means in the alimentary system, will help us delineate if any injury to injury to the blood supply in any abdomen, like the stomach, intestine.
No. Don't assess stomach blood supply looking at the portal vein. That is not the correct answer. Everything is here confined to the assessment of the liver, because portal vein supplies to liver how much?
So 80%.
So what do you think? If the patient has got a portal venous injury associated with the hepatic injury, where do you place this?
So there can be ischemia. So if there is portal venous injury, so there can be ischemia to other abdominal organs.
So going to a hepatic vascular injury. It's a more severe injury.
Yes, sir.
Don't assess the GIT with portal vein localization.
Okay, sir. So, sir, in this case, sir, we will assess for the portal venous injury, and sir,
so you look for any vascular injury, be that in the portal vein, be that in the hepatic veins. How
sir,
many
if it is
hepatic veins?
confined, sir, if it is confined to the
how many hepatic veins are there in the liver?
three, sir. Right, middle, and left hepatic
Where do
vein.
they drain into?
Sir, IVC, sir.
Which part of the
Inferior vena cava.
IVC?
Sir, retrohepatic part of the inferior vena cava.
Suprahepatic part of the IVC. Just above the liver. Just above the liver. So you will look for any evidence of injury to the portal vein, to the right portal vein, to the left portal vein, or branches. You look for injury to any of the main hepatic veins, that is right hepatic vein, middle hepatic vein, left hepatic veins, and you will look for any injury to the inferior vena cava, either above or behind or below the liver.
Okay, sir.
Okay. If there is an IVC injury, if there is a major IVC injury on it, what will you see? Will you see the IVC injury on CT? What will make you suspect?
Sir, we will, sir, from the CT, it is difficult to come to a conclusion that there is direct IVC injury. Sir,
What
in that
the
case,
CT will make you suspect that there may be IVC injury?
Sir, patient is hemodynamically unstable,
What
but
in
we
the
are not.
CT? Why are you answering about what findings on the CT scan will make you suspect there is an IVC injury?
Sir, a contrast blush in the venous phase.
Or
Um,
hematoma around that area?
hematoma. Okay, hematoma, sir.
Hematomas around the area will make you think first.
Okay.
Okay. Now you have told us the grading of AST. Dr. Shah has talked about the WSES. Now, on the basis of this AST grading, is there any grading which tells us that the patient has to be taken directly to OT, irrespective of anything? Stable
Sir,
patient, completely
sir,
okay.
1/3 of grade 4, grade 5 injuries has to be.
Is there
enough.
any grade 1, 2, 3, whichever grade in which we have to take the patient for surgery? Will need surgery.
Sir, grade 5, sir.
Grade 6.
Grade 6. I mean grade 6.
More and more and more, everything
Sir,
is managed
more than
without.
75% parenchymal means liver disruption and devascularization of liver.
You are mixing up between 5 and 6.
Yes.
Okay, so 6 is a definite indication for surgery. Although it's a big question, what can be done? That's a separate thing. But grade 6 cannot be managed conservatively. There is no role of non-operative management of liver injury in grade 6.
Okay, sir.
Everything else, there is some role or other. So, okay, so the CT scan has been done. And would Professor Shah like to tell what are the findings on CT so that she can proceed? What grade are we discussing after this?
Yeah. So assume that CT report has come back to you saying that the patient has got grade 4 injury. Grade 4 injury. So that is a situation of some intermediate situation. If you take WACS, it can go to moderate or it can go to severe based on the human stability. So you get a grade 4 injuries.
So that's parenchymal disruption, 25 to 75% of the hepatic lobe.
Yes, sir.
That's grade 4.
With confined hematoma in the liver parenchyma.
Yes. What should be your approach? If you take algorithm, how do you go? Grade 4 injury management is this.
Sir, we will check for hemodynamical, if the patient is hemodynamically stable or not.
Okay,
if the
stable.
patient is stable, we admit
Proceed.
the patient.
No, Ishita, stable. What is the next line?
So we admit the patient in the intensive care unit.
Yes.
And we go for non-operative management provided there is availability of interventional radiology 24 hours associated with OT facility 24 hours.
So at every time in liver injury, there are a few things that you have to repeat again and again. So first is in liver injury, one, you will always talk about hemodynamic stability. So everything should, if the patient is hemodynamic or unless the patient is hemodynamically unstable, we will do this. That is number one. And you will always talk about, we have excluded other injuries, other abdominal injuries. What is the most common indication for surgery in liver trauma? What is the most common indication for surgery in liver trauma?
So grade 6 and associated visceral
injuries. These are rare injuries. I can understand.
Rare. So rare the most common indication
perforation,
is
sir, perforation.
Of?
Sir, hollow viscous injury. So from the small intestine or stomach.
So other associated intra-abdominal injuries are the most common reason why patients are operated.
Yes.
Liver injury should rarely be a reason. In fact, liver injury should be a reason not to operate if possible. Okay. So we are talking about a hemodynamically stable patient or a patient who has been resuscitated after initial instability. In that situation, with other associated intra-abdominal injuries has been excluded. So you're now admitting the patient to the intensive care unit because your hospital has some prerequisites which are required for a patient to be treated with non-operative management of abdominal trauma. So for NOMAT, your hospital has to have some facilities available. One facility is already available, CT scan. Second facility is available, that is you have an ICU.
Yes, sir.
What are the other prerequisites for sitting on that hematoma and injury?
Sir, this interventional radiology, sir. Facility of interventional radiology and OT facility is the availability of surgeon, anesthetist, 24 hours.
Availability of surgeon and interventional radiologist who have expertise in dealing with these kind of injuries.
Okay.
Then,
So great for injury. Apart from surgery, what can be an intervention and when it is required?
So we can go for angioembolization, sir. And
When you need angioembolization is a therapeutic procedure. What is the situation you take the patient for angioembolization?
sir, increasing size of the hematoma, sir.
And
And
any CT finding?
sir, grade
Hematoma
4,
and
we can take the patient up for angioembolization prophylactically also.
unless you have a demonstration of extravasation indicating active bleed,
Okay.
angioembolization is not mandatory.
Okay.
Only
Sir.
hematoma is not the indication for a angioembolization. So in CT
Okay.
scan, you find patient has got evidence of blush or there is an expanding hematoma. Okay. And the precondition for angioembolization is what? You cannot take all patients.
Hemodynamic stability, sir. Hemodynamic
Yes.
stability.
So patient should be hemodynamically stable for the patient to undergo angioembolization.
Yes.
so you realize one important thing, that even if you find there is extravasation of contrast, that will not actually decide the CT grading. There's no
Yes.
finding like that. So extravasation of contrast will be applicable across all. So angioembolization will be applicable across all grades, provided hemodynamic stable.
Stability. Yes, sir.
Okay. Now what? Patient is admitted in the ICU and is stable, and you have done the grading. And clinically, what are the things that you will always be worried next day, next morning, or the next day after? Major liver injury, what are the problems that can occur in patients?
Sir, any biliary fistula, any biliary liver abscess.
Blunt trauma. You see, you cannot find fistula. You just tell the other things.
Sir,
You don't have a
hemophilia.
outside opening. So fistula will not be there.
Hemophilia, sir.
Yes.
Hemophilia.
Clinically,
So clinically, we may expect signs leukocytosis with a fall in hematocrit and patient going pale. Blood.
One is you try to say the continuing bleed. That is one.
Yes,
Okay.
sir.
Next.
So
So the major.
there are three important things in liver
Yes.
injury that you will be worried about. One is hypothermia. Two is
hypothermia,
lactic acidosis or metabolic acidosis.
and
three is,
coagulopathy.
yes, these are the three things which are specific to major liver injuries, which you should check every day.
Okay, sir.
How do you suspect patient has got a biliary injury causing intraperitoneal bile collection?
Sir,
Another consequence of major hepatic trauma.
yes, sir. Patient may develop, sir, jaundice, and sir.
Before jaundice? Before jaundice
there
develops?
will be, sir, localized abdominal right upper quadrant rigidity and tenderness.
So pain will increase. You see, once the patient has got a biliary leakage and this bile gets collected in the peritoneal cavity, patient will have increasing pain abdomen. Bile
Yes,
is an
sir.
irritant.
Yes.
So increasing pain abdomen, increasing rigidity. Okay, jaundice may occur, but simple liver laceration causing biliary extravasation may not cause jaundice at the beginning.
Okay. It will give rise to biliary peritonitis and subsequently increased tenderness. And
or there may be a simple localized biliary collection in the form of a biloma.
So you have to say that in the
Yes, sir.
initial days, in the early days, if we find fever, if we find increasing tenderness, although there is hemodynamic stability, if we find evidence of localized guarding in some particular area, leukocytosis, then we will have a suspicion of either the blood hemoperitoneum is irritating the peritoneal cavity, or the blood is getting infected, or there may be bilious collection, or they may be missed bowel injury, which may start becoming manifest later.
Yes. Okay. Okay.
So how do you manage? This patient, while in observation, you find there is, you are doing a serial ultrasonography,
Yes.
or
Sir.
you can repeat CT scan also. And you find there is a collection in the right upper quadrant. And patient having fever, patient has got tenderness in sight. So what should be the management?
Sir, in case, sir, we suspect that if there is any liver abscess or any bilioma, then we can go for image-guided percutaneous drainage.
Yes.
And sir,
So again, it should be a conservative, image-guided aspiration.
yes,
Agreed.
yes, sir. And then if we suspect or if we see in CT scan that there is any hemophilia, then we go for angioembolization of the artery, causing the means.
CT scan cannot show you hemophilia. Try to understand. Hemophilia is a clinical manifestation. CT scan can show you some pseudoaneurysm or some extravasation.
Okay, sir. Sir, in case of suspected hemophilia, then we have to go for angioembolization of the respected vessel. And sir, we can also go for ERCP, sir, with stenting.
There was, as sir said, there was a collection. We did an ultrasound. On ultrasound, they put in a needle, they show that it is bile. After confirming it is bile, in that collection, what will you ask the radiologist to do?
So we will means at that site we will go for percutaneous. From the ultrasound, we can determine the volume of the collection.
Large collection.
And then we can go for a pigtail catheterization.
A pigtail catheter is done. Now a pigtail catheter shows there is bile. Next day, again there is bile. Large volume. What will you do?
Sir, we will go for ERCP, sir, after that.
Fourth day after surgery, there is bile coming. Do you need to do ERCP?
Sir, then we have to explore and go for hepatico-jejunal anastomosis.
No, I can't do.
So you have to assess the patient. If there is patient has a collection and it is coming out nicely in the drain and the abdomen is soft and patient is comfortable, then there is no hurry. This is called a controlled biliary fistula. Okay.
Yes.
So yes, ERCP may be an option, but there is no hurry right now to do an ERCP. Okay.
Okay, we can discuss some part of surgical management. Okay, suppose Ishita, you have explored the abdomen in view of other acute injury, there is a gut injury, and find there is a major hepatic injury, not avulsion, but there is good amount of tear, some active bleed. So what is the surgical approach for liver trauma?
Sir, if there is a hepatic injury which we make rectify it with topical hemostatic agents, then first we will pack, sir. First we will do the 4-quadrant packing, and after stabilization we will remove the pack to determine the area of bleed, and we can proceed in that area with local hemostatic agents like fibrin glue and oxidized cellulose. If it is not being controlled on that, then we will go for Pringle maneuver, sir. That will determine if it is a arterial bleeding or the venous bleeding. And if
you see, another part of operative management is, as I said, that most of the hepatic injury you are exploring as the patient with hemodynamically unstable patient.
Yes, sir.
Maybe grade 3 or grade 4 injury, but patient is hemodynamically unstable patient. That patient you are exploring. So once you are exploring the patient, this patient has got a already compromised vitals.
So then we'll
so
go
what
for
is your
damage
idea?
control.
What is your idea of surgery for hepatic injury? What are the aim?
Sir, we will control the bleed and we will control the contamination, and we will go
So
for
primarily two things. One is control the bleed and control any biliary leak. That is the two important aspect of hepatic injury management. And do you think in a patient has got hemodynamic instability and you find there is a gross injury, you go for a major hepatic dissection in the first exploration?
No, sir. We will pack and temporarily close the abdomen, and wait for the
So
patient
the
to
term you
recover
should
from
use is,
lethal
the
trial.
term you should use is, you should go for damage control surgery. In this setting, patient who is hematologically unstable and you are exploring the hepatic injury, your idea will be go for a damage control surgery. So what are the components? Why you are going for damage control surgery?
So on the
Yes.
lines of damage control surgery, let us give you a different situation. Patient is completely hemodynamically unstable, came to the emergency, rushed to the OT, and you don't know anything. You have just opened the abdomen, and on opening the abdomen, you find that the liver is shattered, it's bleeding, the bowel is torn, the bile duct is torn, and the ureter is torn. Okay.
Okay,
And you've gone, and the spleen is completely shattered. Okay, there are rarely such kind of situations. Suppose you open. So this is a condition, stay unstable. Anesthetist is saying, please quick in, quick out. So what will you do? You go in, now abdomen open, what will you do?
so we first decontaminate it. It is already contaminated. We first evacuate it, and then, sir, we pack.
You open
pack
the abdomen, if you evacuate, everything will, you wait for evacuation, the blood will keep on coming.
Sir, we pack it, sir.
Yes.
Pack the all 4 quadrants, and sir, for this one bowel injury, sir, we
No, you
will
have packed.
staple.
You've just packed. You've put packs in. The abdomen is stuffed with packs. Now what?
Sir, we will bowel injury, sir. We will just put the
Right now there are packs.
stapler.
You can't see anything right now. There are packs. Now what will you do at that moment after packing?
So then we will temporarily close the abdomen and
No, first you will tell the anesthetist that is the patient stable. You want to
Yes.
give some fluids. So you get a time to breathe now after packing. Okay. The anesthetist gives some fluids and then said, okay, we have some time. So now go ahead. So now what will you do? There are packs inside.
so then we will slowly remove the packs one by one to check
Which
for
pack?
One by one meaning?
Which pack first? Remove the pack around the liver first, or where?
Sir, liver will be last, sir. Yeah, and
So first you control the GI tear. What do you do? A formal anastomosis?
no, sir, we will put stapler at the, we will resect the part of perforation and we will put stapler at either end.
To join.
There is a guard transection. There is no question of resecting now. Patient is very
There are
critically.
two ends of gut like this. What will you do?
Yes.
So we will just put stapler at both the ends and we will do some formal anastomosis later.
So you're going to close the two ends.
Close.
Yes.
You're going
Just
to
to
close
prevent
the two ends
contamination.
with stapler. If you don't have stapler, then
We have to go for hands-on
you
anastomosis.
just tie it.
Okay.
You just tie them close first.
Okay.
Next.
Sir, then we will take care of the ureter injury, sir.
Okay. Can do later also.
And
Because ureter is not bleeding. It's not really, but yeah, you can.
okay. And
so
sir,
what will you
then,
do? Finally to the ureter, what will you do? It's transected.
Sir, that also, sir, we will tie both the ends, sir, in the ureter.
Or?
Sir, once we will check if the other ureter is
fine.
viable.
One ureter is fine. Left
So then
ureter is transected. What will you do?
So then we can we can tie both the ends and go for a formal transureteral or ureteral anastomosis.
No, you can put in a pipe inside the ureter.
Okay.
And tie on the pipe. And so later you can, so the urine will come outside. No?
Okay.
Okay. So you can
do minimum. Do minimum in this situation. There's no question doing an anastomosis in this setting.
Yeah. Okay. Next.
And then, sir, we will go for splenectomy.
After, so if the artery is torn, vein is torn, and you can just easily you feel a splenectomy is done, okay, maybe doing. Okay. Then.
So then we will remove the pack around the liver to assess for the site of liver injury, sir.
So you cannot assess, it's bleeding.
Sir, then we will go for Pringle's maneuver to determine it to be any arterial or means to differentiate it from arterial portal venous bleeding from the
It's still
venous
bleeding.
vein.
In spite of Pringle, it's bleeding.
Then we have to, sir, isolate the liver from the vein, sir, by that.
What are we doing? We are doing damage control surgery.
Yes.
Sir,
The patient is going to die within minutes.
so then we will again pack, sir.
Yes. Now, what do you mean by packing?
Sir, we
How
have
do you
to,
pack
sir,
the liver?
Yes.
How do you
What is
effectively
what
pack?
is perihepatic packing?
Yes.
so sir, we will divide the triangular ligaments and expose those areas and pack, sir, all around the liver, sir.
Yes.
So, in the context of hemodynamic instability, we will still try to mobilize the liver as far as easily possible and put mops all around the liver. Typically, at least 10 mops are required. And the important component is that if there is any fracture, we try to bring that together. So we pack around the liver, don't pack into the fracture because that sort of opens it up.
Okay.
And the very good way of saying is never say packing of the liver, never say I will pack the liver, but use the term perihepatic packing, as sir just said. If you keep saying perihepatic packing, then you'll always remember in your mind that you have to focus on mops all around the liver. So perihepatic packing is the perfect way to remember it.
Okay, sir.
Then?
So then we will wait for the patient to stabilize. Means after we will temporarily close the wound and we will wait for stabilization
There's
of
bile
the
duct
patient.
injury as well. The bile duct is transected. What do you do?
Sir, sir, in case of bile duct injury also, we will tie both the ends and come out.
Yes, you can tie
Yes.
both ends and come
Or
out.
you can just put a drain.
Again, you can
Yes,
put a
drain
drain in that area.
Yeah.
Or you can, if the CBD is there, you can put a pipe inside the CBD, tie over it, take it outside. Whichever you feel is easily doable at that time, you do it.
When
Then
is the time to go in again? When? At what time?
As and when patient stabilizes
When is it?
within 24 to 48 hours.
Yeah. It may be 24 to 72 hours even. So in that time, what you are likely to achieve?
So we have achieved, sir, hemostasis, means we will metabolic acidosis has subsided and hypothermia and coagulopathy has also been taken care of, and then we go for a more formal
And you should resuscitate
formal
the patient.
repair. Yes.
so between the first surgery, damage control, and the second surgery, what is the most important thing besides resuscitation? What else will you do for the liver injury?
Sir, CCT, sir.
Yes, you still have to grade the liver injury because it is not possible to do it at the time of surgery. So grading of liver injury is not done at surgery. It is done at CT scan. You may find something which can be dealt with angioembolization rather than again opening without planning for that.
Yes. After exploration, after first exploration, if you have a documented extravasation and now the patient has become unstable, there is a role for angioembolization because your surgery become easier. When you re-explore, you may find that the bleeding is already controlled.
Okay, sir.
Okay, we have discussed for 1 hour. Okay, so you see, basically, Ishita, the approach is important. In exam, you will have only 10 minutes. You have 10 minutes or at best 5 minutes for a whole discussion on liver injury. So examiner will see your approach. How do you approach a patient? We have given a scenario of abdominal injury. So don't make your vision to abdominal injury also. So you say, I'll do a comprehensive assessment by ATLS protocol, following ABCDE, and then abdominal injury, you'll take a detailed history, do an examination, and go for EFAST, followed by some relevant investigations. And then let the examiner ask grading of injury, that non-operative management, indication for operative management. So what are the indication for surgery in liver injury? Indication for
Pardon, sir,
surgery
indication
in
what?
liver injury.
I did not get, sir.
Indication for surgery for liver injury.
Sir, gross signs of peritonitis and
What?
hemodynamic instability.
Hemoperitoneural will cause peritonitis. Hemoperitonum will give signs of peritonitis, all tenderness, rigidity. Is it the indication?
Yes, yes,
Give
sir.
a specific answer. Liver injury
Sir,
associated with
shock,
other injury
shock,
requiring laparotomy. Any
sir,
grade of
shock,
liver
signs
injury.
of peritonitis.
Any grade of liver
Okay, sir.
injury with an associated injury intra-abdominal, which dictates that the laparotomy has to be done. Number one, grade 6 liver injury and other grade of liver injury with a situation of hemodynamic instability. So these are the prime indications for laparotomy in patient having liver injury. Okay, so all liver injury does not require. Majority of liver injury, 80 to 90% liver injury are managed with conservative measures, NOM, non-operative management. Dr. Rai, any last tips for the students? I think we have discussed the approach.
Yes, sir.
Dr. Rai, any comment?
I missed the question. Did you ask any question?
Yes, I said any last minute tips for the student to approach such scenario.
For you particularly, Ishita, I think examination is not only about knowing. You have to have a style of answering. You have to have certain dialogues, certain ways of answering ready. Like when sir asked that what is the indication, you have to have a system in your mind for everything. There are 4 or 5 lines that you always have to say, that you have to keep practicing, which is not happening. You're just answering line by line. You ask a question, you're saying one point. So at every day, you have to practice saying those lines, like hemodynamic instability, said, associated injuries, said. When we talked about certain liver injury, we have to say those 3 things of metabolic acidosis. Those sets of things you have to keep in mind, which you have to make points. Otherwise, you'll not be able to answer in the exam.
Exam of 5 or 10 minutes, try to understand. In that 10 minutes, you have to prove that you know the approach. There is no question of going for 1 hour for a liver injury exam scenario. Everything is over in 5 to 10 minutes. Okay. Thank you, Dr. Rai.
Thank you, sir. Thank you very much.
Thank you.
Thank you, sir.
Thank you.